practice area. So we must all join hand together and try to make our own area TB free. If you are able to do that, we can produce models for the government, and that those models can then be replicated throughout India. Now, coming back to the spread of knowledge and taking people together, it is highly important and pertinent to have alumni of the subject of the college in which one is teaching. And I remember in my own college, we also made an alumni by the name of CMAM, that is Community Medicine Alumni Association of LLRN Medical College. And I'm really delighted to know that Unappa Medical College has also got an alumni association of community medicine. And it's a very, very welcome step. And I think it's a new arena in which the people living in India are realizing the importance of having the alumni associations. Word over, if you look at the philanthropic aspect of the various people who have risen to greater heights, not word over, even in India, if you look at the IITians, they donate millions of rupees to their IITs, where the IITs are considered to be the premier institutes where there is no dearth of money, but even then the people donate. So it is important to have a strong alumni association, have a great bonding with each other, and transmit the knowledge and experience which one is having, not only from top, but from bottom to top also, because newer things are coming up and newer things are to be shared with each and every one. So with this word, I'll request Dr. Poonam Nayak to kindly release the alumni newsletter so that we can move forward. Over to you, Dr. Poonam Nayak.
Thank you, sir. I will share the newsletter, and thank you for releasing the newsletters. I'll share it. Thank you, Harivansh Chopra sir, for releasing the next issue of our alumni newsletter. So as you correctly said, sir, the alumnus network, it's an example, or it helps mutual learning, and it is not a unidirectional learning that happens. Alumnus network helps us to share our experience, and a bidirectional learning happens in the process. The alumni newsletter of community medicine started as an informal activity and is now gaining momentum with persistent efforts from our faculty coordinators, alumni coordinators, Dr. Pavitra and Dr. Madhavi Bhargava, Assistant Professor and Associate Professor of the department. And of course, with valuable contributions, our alumni network is expanding because of the contributions from our proud alumni. It has strengthened our already vibrant alumni network. This issue, as a Department of Community Medicine with strong public health ethos, is dedicated to remembering the sad demise of Dr. Paul Farmer, who has inspired community-oriented work globally. Editors also suggest some of his best books that is essential for we public health professionals to read and learn from them. This issue also features a very heartfelt message from Dr. Prachet, who worked with us and was associated with the department and the institute for 7 years and is now our alumnus. Our contribution to the department, institute, and to the community, and the work that the department has done in close collaboration with the district administration and the district health and family welfare got featured in the university magazine ICRA. And here are some of the snippets where we launched the immunization, the Covishield co-vaccine, and also we were the first institute in this region to introduce the Sputnik vaccination, the different community and outreach-based activities. We believe in strong public-private partnership, and thereby we also inaugurated a new urban health center in collaboration with the Mangalore City Corporation last month, so that we have a greater community outreach. We look forward to strengthening and continuing engagement with our alumni, and their achievements make us feel proud as they have contributed to the growth of the department in many different ways. Thank you. Over to you, Dr. Pavitra. I will stop presenting.
Thank you, ma'am. Thank you, sir, for your opening remarks and for releasing the alumni newsletter. Thank you, Poonam ma'am, for summarizing this issue. Now I request Dr. Akshay KM, Additional Professor, Department of Community Medicine, Nnrtis Medical College, NTP Nodal Officer, and Organizing Secretary for today's event, to declare the prize winners of the e-poster competition held. Over to you, sir.
Yeah, good afternoon, everyone. Hope I am audible.
Yes, Dr. Akshay, you're audible.
Yes, thank you, ma'am. Yeah, the Department of Community Medicine, in association with National Service Scheme, Nnrtis Medical College, had organized an e-poster competition for all the undergraduate students and interns of Nnrtis deemed to be university. We were inclusive in this, that we had included all the students of all the constituent colleges, and this was one of the activities to mark the World TB Day 2022. Our focus was basically to look at patient education in tuberculosis, and we had kept the options of the posters to be designed in Kannada, Malayalam, Hindi, as well as in English. So since Malayalam is also one of the common languages in the border area of Karnataka, where we are having our medical college, we had this also. And in this poster competition, we had sent the posters with a structured checklist for evaluation to 3 evaluators. I sincerely thank the 3 evaluators, Dr. Navya N from Department of Community Medicine at our Nnrtis Medical College, Dr. Maltesh Undi, who is serving as Assistant Professor in Karwar Institute of Medical Sciences, and also Mr. Amrut, who works in the Department of Public Health as Assistant Professor in Nnrtis deemed to be university. So after this particular activity of evaluation, we concluded that we need to award first and second prizes and 3 consolation prizes. The first prize goes to Miss Fiza Nazreen and Faiz Mohammed of 2019 and 2021 batches of MBBS from Nnrtis Medical College. So this was a Malayalam poster which was designed by them. So we hope to translate this into Kannada and as well as English and use in our patient waiting areas, including our both urban and rural health centers. The second prize, which was designed in the language of Hindi, and this particular prize goes to Ms. Srishti Das and Ms. Akanksha Pai from 2019 MBBS batch, and this was the poster which was designed by them. And we have 3 consolation prizes or third prizes, Mr. Arshad and Ms. Mina Sahib from 2019 batch, Ms. Grishma and Ms. Mavia from 2017 batch MBBS, and we also have a poster which has won the consolation prize, which comes from homeopathy BHMS course, Ms. Sinalda Cardosa and also Ms. Jafna Jasmine. So we congratulate all the winners in this particular poster competition, and these posters have come out really well, which we can use it in our patient waiting areas. So these were the 3 posters. Okay. The next part of this particular event would be the most anticipated one, where we were looking for the guest lecture on the topic of programmatic management of programmatic management of TB preventive therapy, and this particular lecture would be given by Dr. Shasia Anjum. In brief about Dr. Shasia Anjum, Dr. Shasia Anjum completed her MBBS in 2007 from Devarajaras Medical College, Kolar, and then she went on to get her Diplomat of National Board from Community Medicine. She even did her Masters of Public Health in Field Epidemiology from National Center for Disease Control, New Delhi. She has been a gold medalist in this particular course as well as during her undergraduate days in community medicine as well as in OBGY. So Madam joined the World Health Organization as a medical consultant to provide technical assistance in the year 2011, and she has been serving as the state consultant from that particular time. So two important things which she has been involved with are the National Technical Expert Group for Drug-Resistant TB in the Central TB Division, and she is providing technical assistance to program in framing national policies, monitoring guideline implementations, data validations, and so on. Also, she is interested in the field of operational research too. So, Madam, I would like to hand over the mic to you so that you can take over the presentation from here.
Thank you, Dr. Akshay. At the outset, I thank all the administrative authorities of Nnrtis Medical College, along with Dr. Chopra sir, Dr. Poonam ma'am, and all my other colleague friends and the faculty and the postgraduates. I understand that it's not just Nnrtis Medical College, but quite a few other colleges also have joined the seminar now. So without much ado, let me make my presentation on the programmatic aspects of TB preventive therapy. Dr. Akshay, is my screen visible?
Yes, ma'am.
Okay, so
yes.
So thank you very much again, and let's start off with this session. I'll be not talking to you about the global or the Indian statistics as such, but I will take you through the entire presentation of the guidelines for programmatic management of tuberculosis preventive treatment in our country. So let's look at the overview of this TB infection. To understand, we all know that India has the highest estimated burden of TB infection globally. We all know that it is almost 26%. So with nearly 35 to 40 crore Indian population having TB infection, out of which only about 26 lakh are estimated to develop tuberculosis disease. So what is important is 5 to 10% of those who are infected will develop the disease over the course of their lives, usually within the first 2 years after initial infection. But you also need to understand that there are a number of risk factors which will actually propose an individual for the development of disease. The most important one being immunological status. So if you look at this, the first one is HIV, which shows that there is almost a 16 to 21 times higher in case of TB HIV co-infected. The second of which, in fact, the biggest category now is the bacteriologically confirmed TB patient contacts. So the contacts have almost more than 25 times risk of developing the disease. The third one is other immunocompromised conditions, could be diabetes. Of course, undernutrition is a must-say risk factor now. Also, you will also have to understand that 75% of the people who develop the TB disease after contact with a patient of active TB are estimated to do so within the first year of diagnosis. Maximally, 97% would actually land up in active TB disease 97% of the times within the first 2 years of the disease, within the first 2 years. So anybody who is infected landing up into an active TB will happen mostly in the first 1 year or maximally at the first 2 years of that particular contact period. So the risk of developing TB disease after TPT actually decreases by approximately 60%, and the reduction can be up to 90% in PLHAV. So this has been a very confirmatory statement, as we have already seen this in the program. So we are treating the HIV patients with the TPT for almost 4 to 5 years now, and we are not seeing a single TB case being developed after being treated with TPT. So that is the good news. So here it is very clearly shown that the success rate could be almost 90%. So there have been a number of studies which are published on the evidence of the TPT preventing active TB among household contacts. So one such study is what is being given here. There were 1,051 household contacts as a sample size. 71% household contacts of pulmonary TB patients had the baseline TB infection of more than 5 millimeter or quantiferon gold of more than 0.35 IU per ml. So all in all, if you look at this, this can vary across the country, especially now that the program has incorporated TPT in the mainstream guidelines. There are districts, like one of them is Chikbalapura. Hardly there are 30% of the household contacts do have a positive, infection test. But according to the study, it is almost 71% contacts have a infection test being positive. So overall, what is important is this particular point, that only 2% of the household contacts developed incident TB disease, which is 12 cases per 1,000 person years. But there are a number of losses and dropouts at each stage of cascade care. The numbers which are intended to screen, the numbers which are initially tested for infection, the numbers who receive a test and finally turning out to be positive is somewhere around 56%, and then people completing the medical evaluation is hardly 44%. Finally, if you look at somebody who is actually treated on a TB preventive therapy, it's hardly 18%. So now it's very difficult for us to say that 35 to 40 crore population of India will have to be treated for TB preventive therapy so that we can prevent the occurrence of active TB. Now that's a very big target. That is almost impossible to be achieved. That is the reason Government of India came up with these guidelines in the year July 2001, wherein they have actually chosen the target population for TPT. So this is what is a target population. The first set which is mentioned here, basically the HIV positive patients, whether it is adults or children. The second one is the household contacts below 5 years of pulmonary TB patient contacts basically. So these two groups are the ones which we have already rolled out. It's almost in vogue from the past 4 to 5 years. We are giving chemoprophylaxis to both the HIV positives and the household contacts below 5 years of contacts of pulmonary TB patients. TPT is being given in the form of isoniazid for 6 months daily. But what is a new inclusion? The new inclusion is this particular point of household contacts 5 years and above of pulmonary TB patients. So this is a new inclusion wherein every adult contact is now considered as a target population for TPT. The other ones which are considered as target populations are those on immunosuppressive therapies, those who are having silicosis, those who are on anti-TNF treatment, on dialysis, or somebody who is undergoing a organ transplantation. So let me take you through each of these categories. So the number one category I've already mentioned is HIV, where you have decreased the overall risk of developing active TB by 60 to 90%. On the other hand, adults and children more than 12 months living with HIV should be screened for TB using the 4-symptom complex, and only then can you provide them with TPT. This statement is very, very important. So if you don't rule out active TB and start the person on a chemoprophylaxis or a prophylactic therapy, it is going to be criminal. So be very careful of this fact that you have very, very confirmatively or assertively ruled out tuberculosis. So the best method to rule out TB among HIV is just doing a 4-symptomatic complex screening. So there are 4 symptoms, which is cough of any duration, fever of any duration, night sweats, and weight loss. So any of these symptoms present in a HIV positive individual will have to be thoroughly evaluated for tuberculosis. If that doesn't happen, if somebody doesn't have any of these symptoms, then you can straightforward consider these as eligible for TPT without any further confirmatory tests of ruling out active TB. So if you have ruled out using an 4-symptom complex, that will suffice. The second one is the infants aged less than 1 year living with HIV who are in contact with a patient of pulmonary TB, are investigated for TB, should receive TPT with 6 months of isoniazid after ruling out active TB. So the only difference here is in a child who is less than 1 year, it's highly difficult for us to enumerate the 4-symptom complex, and that is the reason why we would require a ruling out of active TB, maybe by a simple NAT test and with whatever available specimen. Only then can you start this child on 6 months of isoniazid. The second group is the household contacts. Now the household contacts get divided into 2 groups. The first group is anybody who is under 5 years of age, and the other group is anybody who is more than 5 years of age. So for anybody who is less than 5 years of age and a contact of a pulmonary microbiologically confirmed TB patient, then you will only have to rule out active TB again with the symptomatic screening, and there is absolutely no need of confirming the infection in both the scenarios. In scenario 1, that is the HIV positive patients, and in scenario 2, where the kid is of less than 5 years, you need not test for a TB infection. You need not do a IGRA test. You need not do a TST. You can straight away start them on the TPT. So that is a rule which applies for any contact below 5 years of age and all the HIV positive individuals. Now the second group is where is the new addition, which is the children or adults more than 5 years. Okay. So here is a chance and an opportunity that you will have to first rule out active TB, at least get an X-ray done, and then at least propose it for a NAT if at all there is an abnormal X-ray. But if there are no symptoms and the X-ray appears to be a normal X-ray, then you will be able to offer TPT provided you get a confirmatory test of TB infection. And that particular confirmatory test is basically IGRA. So we are not relying too much on the tuberculin skin test. Rather now we are relying heavily on IGRA, which is interferon gamma release assay. So that is what is being given here now. Now let's go to the third group, which is the other groups. So very importantly, anybody who is on silicosis, anti-TNF treatment, on dialysis, preparing for organ or hematologic transplantation should be tested and treated for TB infection because of their increased risk for progression to active TB disease. So the most important point here is you will have to rule out active TB just like the other groups. However, you will also have to confirm the TB infection using a IGRA. So if you are planning to, offer a TB preventive therapy to any of these groups, diabetes, malnutrition, smoking, harmful alcohol abuse, or people who are undergoing, organ transplantation, hemodialysis patients, and all these will have to be looked into. I mean, you will have to first analyze and assess whether the person has got active TB. After ruling out active TB, now you offer them an IGRA. Confirm the TB infection with an IGRA, only then will you be giving them a TB preventive therapy. But as of now, we are not recommending in the program guidelines to screen these groups, especially diabetes, malnourished, smoking, and alcohol abuse. But the other groups which I mentioned, silicosis, anybody who is undergoing an organ transplantation, anybody who is on anti-TNF factor, anybody who is also into the vulnerable risk groups, like while we do an active case finding, we have a number of vulnerable risk groups. All these can be taken up for TPT. Now, this group, diabetes, malnutrition, smoking, alcohol abuse, have been restrained for TPT as of now in the guideline, but you're open to do an operational research on all these groups. So I leave it to the college authorities to think of an OR on these groups. Sorry, my throat is also very bad today. Let me now take you through the diagnosis for TB infection. So there are very simple tests. One is the tuberculin skin test. The other one is IGRA, which is interferon gamma release assay. you know that TST is a skin test, and it's a very skill-oriented test, which actually detects the immune sensitization by type 4 and delayed type 2 hypersensitivity to mycobacterial protein antigens. But since it is highly skill-oriented, it may not be feasible in the field. Especially many of us do not even know on how to read the induration. So forget about the field stuff. So we will not rely about the TST. Also, many of us do not know what is the exact strength of the PPD to be used, whether it is 2 or 5 or 10. So there are a lot of confusions in the field. So it's better to stick to the in vitro interferon gamma release assay, wherein a proper interferon gamma released by the white blood cells when they are mixed with mycobacterial TB antigens, or the number of T lymphocytes producing interferon gamma is the actual measurement which is done. And this is the one which is going to confirm infection, TB infection. You also need to understand that in no way both of these tests will be able to differentiate between TB infection and TB disease. So this is an important aspect you should remember. Now, how do we enumerate the target population and rule out active TB disease? So there's a simple algorithm. So understand that this algorithm starts with the HIV positive. The second group is the household contact. The third group is any other risk groups. Just see if I have a pointer. Yeah. So if you look at the HIV positive, so if it is any of these 4 symptoms is present, then you will have to investigate for active TB. If none of the 4 symptoms are there, then no need to investigate for active TB. Straight away, you can start that person on TPT if there is no contraindication for TPT, right? But if there is any of this symptom which is present in the HIV positive individual, you better investigate for active TB. The simplest method is by offering a CB-NAT or a true NAT. So you confirm that there is no TB. So if at all your NAT test says that there is no active TB, you can proceed with the preventive treatment. If there is any contraindication, you may defer. That's it about HIV positive. Now look at the household contacts. There are 2 types of household contacts. One is a symptomatic, or the second one is not symptomatic. So if there is a symptomatic household contact, first get him evaluated for TB, again by offering a NAT test. But if there is a asymptomatic contact, then classify it into 2 groups, whether it is a less than 5-year child or a more than 5-year adult or a child. So if it is a less than 5-year child, then you will have to again see if there are any contraindications for TPT. If there are no contraindications, go ahead and start the TPT. All these groups, HIV group and the less than 5-year group, need not be confirmed for TB infection. So irrespective of IGRA, these people can be started on TB preventive therapy. The only, the crux is that you rule out active TB, especially if they are symptomatics. The second thing is you will also have to look at contraindications. If there are no contraindications, just proceed and complete the TB preventive therapy. Now comes the newer addition, which is the more than 5 years age group, which is actually to be tested on a TST or IGRA. So if at all your TST or IGRA is positive, then here comes a game changer. You will again have to do a chest X-ray. Now, if the chest X-ray is normal, only then you will proceed for a TPT. But if the chest X-ray is abnormal, you will have to investigate the person for active TB. Now, this is a very, very important point, because all these days we never used to bother about chest X-ray screening of any presumptive TB. You may now say that this particular contact who is more than 5 years or adult is not even asymptomatic. Then why are we doing a chest X-ray? See, it was asymptomatic initially, and that is the reason we proposed a TST or IGRA. Now that the IGRA and TST is positive, we would want to doubly confirm and doubly assure ourselves that there is no active TB, and that can be done only with a chest X-ray. You all know that even if the chest X-ray shows any abnormality, irrespective of the TB signs or whatever features on the X-ray of TB, you will have to assess this particular person for active TB. Rule out active TB by offering a NAT test and then proceed. But then if the TST or IGRA is negative, forget about it. You need not take them for TPT because you're not even infected. So here is the game changer, where any adult or anybody who is more than 5 years getting offered a TST or IGRA, and if the TST or IGRA is positive, you will have to further drill down and get an X-ray done. If the X-ray is normal, then you can proceed towards TPT. But if the X-ray shows any abnormality, please rule out active TB. Now, this is the group which is actually known as a subclinical tuberculosis, wherein the patient or the contact is actually asymptomatic, but he harbors the disease in the subclinical stage, which might turn out to be active TB in the later stages. This is exactly what has come out in the National Prevalence Survey. Give me 1 minute. Okay, sorry, I just wanted some water. Right. Back now, and then this is what you will have to understand, that the National TB Prevalence Survey was the one which has clearly shown that anybody who is harboring this TB bacilli could be in a latent TB stage or could be in the subclinical stage, and that can be differentiated only with the chest X-ray. So if you do a chest X-ray, it turns out to be an abnormal chest X-ray, please investigate for active TB. I'll leave it for 2 minutes for you to understand. I'll take the queries at the end, but for you to understand, I'll leave the algorithm for at least 1 minute now. All right. Now there's another group which is the other risk groups, and obviously they will have to be tested on a TST or IGRA. But then the same philosophy for the adult contacts follows here, wherein you will have to rule out TB first by doing a chest X-ray, and if there's an abnormal chest X-ray, please investigate for active TB. If there is no active TB, only then proceed to the preventive aspects. What are the contraindications of TPT? Very important and absolute contraindication is active TB disease. The second one is acute or chronic hepatitis. Third one is concurrent use of any other hepatotoxic medications, especially nevirapine. Regular and heavy alcohol consumption, and then if somebody is suffering from peripheral neuropathy or any allergy or known hypersensitivity to any drug which is being given as a TPT. Usually it would be isoniazid or rifampicin. So what is the most important point is the first point, which is active TB disease. You can never think of starting TPT if at all you have not ruled out active TB disease. Also understand that pregnancy or a previous history of TB are not contraindications, and contact with drug-resistant TB has an entirely different regimen, which I'll take you through in the later slides. Now, if you have assessed and ruled out active TB perfectly, and you know that this particular contact is now eligible for TPT, then you will now need to do a simple set of pre-treatment assessments. Basically, look for any allergy or hypersensitivity to the TPT regimens used. Look for the HIV status and the ART regimen, especially if it is on nevirapine, you will have to forego or change the ART regimen. The third one is pregnancy status, because in pregnancy, you will not be able to give certain drugs, especially rifampicin. The other one is the assess the presence of comorbidities. As I've already mentioned, diabetes is one group which is not being considered as of now. Malnourishment is another group which is not being considered for TPT. The third group is anybody who is having, severe hepatitis or is a known chronic alcoholic. Then you will have to delay the TPT initiation. Also look at the history of medications, especially drug classes like ARVs, opioids, and antimalarials. Liver function test is very important if at all you have a chronic alcoholic. See to it that the ALT and AST is actually at the normal. So anybody who is having an abnormal baseline LFT of more than 3 times the upper normal limit in the presence of symptoms, or more than 5 times the upper normal limit in the absence of symptoms, you will need to have a clinical judgment. What is important is you better don't start this person on TPT, because you will always have to weigh the benefits versus the risk, especially in case of chronic alcoholics. Now, what is the TB preventive treatment? So there have been a lot of evidences. One of such evidence is the 3 Hp regimen, which is 3 months of isoniazid and 3 months of rifampicin given weekly once. So it is a 12-dose regimen. So basically for 3 months, weekly once is this regimen of 3 Hp being given. It is said that compared to the 9 months of isoniazid, 3 Hp has a better completion rate. Obviously, the compliance would be good and also sometimes better than our 6H or 9H therapy. So there have been a lot of evidences for 6 months of isoniazid daily, and this is very much evident even under programmatic conditions. Now, this is the TB preventive treatment for each of the groups. Don't get confused because this is all the same. So everywhere either you give 6 months of daily isoniazid or you give them 3 months of weekly isoniazid and rifampicin in persons older than 2 years. So anybody who is less than 2 years and a pregnant lady cannot be given rifampicin, and that is the reason here it is mentioned as more than 2 years. For anybody who is an adult contact, happily you can give with the 3 Hp regimen or with the 6 months of daily INH regimen. And for any immunocompromised people, silicotic people, anti-TNF treatment patients, dialysis patients, or anybody who is undergoing a transplantation should be evaluated for TPT after ruling out active TB, confirming the TB infection with IGRA, and then give them 3 months weekly INH and rifampicin, or you can give them 6 months of daily INH. So everywhere the regimen remains the same. It is either 6 months of isoniazid or it is 3 months of isoniazid with rifampicin, which is a weekly dose given as a 12 weeks dose, which is for 3 months. Only scenarios where rifampicin cannot be given is anybody who is less than 2 years and pregnant ladies. Now, what is the dosage of this INH regimen? For more than 10 years, it is 5 mg per kg per day, and for less than 10 years, it is 10 mg per kg per day. So the bioavailability in children is very low, and that is the reason there is a higher dosage when compared to adults. Now, this is the dosage of 3 Hp regimen. The actually, the weight band wise classification is available. There are 2 formulations. It is either available as loose drug, that is isoniazid separately available as 100 mg, rifampicin separately available as 150 mg, or it can come as an FDC, which is a fixed drug combination of INH plus rifampicin in a single pill. Okay. So for 2 to 14 years, here is the age-wise breakup. And for anybody more than 14 years, this is the age-wise breakup. So the number which is mentioned in this cell represents the number of tablets to be consumed. So take for example, anybody with 31 to 34 kg between 2 to 14 years must consume 7 tablets of isoniazid and 5 tablets of rifampicin if it is loose tablets. But if it is a fixed dose combination, it is 5 tablets of INH plus rifampicin together. So all in all, you should understand that this is a weekly regimen to be given weekly once for a period of 3 months. So all in all for 12 weeks, right? Of course, it's difficult to by heart all this, but I would request you to either go through the guidelines or just attach this as a chart in your OPDs. Now let's compare 6 months of isoniazid with 3 months of isoniazid plus rifampicin. So this is a 6-month regimen, this is a 3-month regimen, this is a daily regimen, here is a weekly regimen. Here we have 182 pills, here hardly we have 12 doses. It could be 108 pills if you are going with the loose drugs, but it could be 36 pills if you're going with the 3-pill FTC. Safe for use in pregnancy, 3 HP is not known. I mean, we will not be able to use it in pregnancy. There is no restriction of using isoniazid with antiretroviral therapy, but for 3 months of isoniazid and rifampicin, there is a clear-cut contraindication not to be used with protease inhibitors, Nnrtis. Toxicity, of course, you know that isoniazid is hepatotoxic. It might cause peripheral neuropathy, and that is where we will be adding pyridoxine whenever we are giving 6 months of isoniazid. For 3 HP, it is usually flu-like syndromes or hypersensitivity reactions. Sometimes it could be orange discoloration of the body fluids, just like rifampicin. Of course, hepatotoxicity is much lower when we compare it with the isoniazid. Now, INH is something which is to be used on an empty stomach, but for 3-HP, it is always better availability when it is given with a meal. I've already told you that pyridoxine will have to be given wherever you're giving isoniazid, especially whenever there is a peripheral neuropathy patient, you better don't challenge that person with isoniazid therapy. So it is better to withdraw or withhold giving isoniazid to that particular patient. And for others, you can give a 10 mg per day of pyridoxine and 25 mg per day in adult, 50 mg per day in adult PLHIV. So this is the dosage of pyridoxine to be given to each of the categories. What are the adverse events? So adverse events are actually very minimal because we know that isoniazid is much safe and we have been using it in the program for years now. The other one is rifampicin. As I've already told you, there could be some hypersensitivity reactions, especially flu-like syndrome. Hepatitis is quite uncommon. And there could be some rare adverse events like hypotension, decrease in WBCs, decreased appetite, and hyperbilirubinemia. Let's look at the special situation. So when it comes to women and TB preventive therapy, there is no evidence that 6H would be harmful. So safely we can start the lady on 6 months of isoniazid, but please do not give them TPT with rifampicin. So it's better to not start the lady with rifampicin regimen. The other thing which you should ensure is pyridoxine, which is vitamin B6, has to be supplemented along with the INH regimen. Contraception, of course, there will be a failure of the contraception and there could be a decreased contraceptive efficacy because of interaction with rifampicin, which is the sister drug of rifampicin. So it's better to change over to other modes of contraception rather than the oral contraceptive pills. I've already told you about liver disease. It's always better to evaluate the patient, especially in cases of hepatitis and in cases of chronic alcoholism. Please look at their AST and ALT levels. See to it that it is definitely within the normal upper limits. But if it has crossed the upper limits, better to bring down the levels and only then think of TPT. Otherwise, it's better to leave alone TPT in cases of liver damage. So whenever there is a HIV patient and you're giving TPT, of course, isoniazid is very, very safe. But if you look at rifampicin, it can be co-administered with efavirenz, but you will have to be very, very careful when you are giving a HIV positive patient with nevirapine and rifampicin. It's better not to go with that regimen. It's actually not to be co-administered with any of the protease inhibitors. Also, whenever a HIV positive person is receiving raltegravir and rifampicin, higher dose of raltegravir should be used. Babies born to mothers with TB disease and TPT, please be very careful here because concomitant admission of both administration of BCG and TPT can happen, but that is not a contraindication. So irrespective of the BCG vaccination status, TPT can be administered. The only condition is that you will have to give them pyridoxine 5 to 10 mg per day. 6 months of isoniazid is very, very safe. But be careful with the rifampicin regimen. Better don't start the baby, especially below 2 years, with the 3-HP regimen. Now there's a unique scenario of treating the contacts of drug-resistant TB. This was never there in the program. We never ever tried treating the contacts of drug-resistant TB. But for the first time, we are trying to treat the contacts of DRTB. Now, the rationale is that there has been a lot of modeling which has happened, and it suggests that 3 in every 1,000 people globally carry MDR-TB infection. So this is the one which has actually now led to these studies, and because of which the evidence has very clearly come out from most of these studies on the usage of levofloxacin as a first drug. The second drug is the usage of rifampicin itself. There are studies in pipeline, like TB Champ is one study, VQueen is another study, Phoenix is another study, where they are using a number of other drugs. Here, 6 months of levofloxacin versus placebo, 24 weeks of levofloxacin, 26 weeks of delaminate. All these studies are still under their clinical trials. But what has come out very clearly is the usage of levoflox. This algorithm is exactly same as the earlier algorithm, so I'll not repeat it, but I'll take you through the regimen and what are the, some sort of conditionalities which you will have to follow before starting the DRTB contacts on a regimen. If at all you are thinking of a 6 month of daily levofloxacin for contacts of rifampicin resistant fluoroquinolone sensitive patients, the first condition is that if at all you have a rifampicin resistant patient, please ensure that he or she does not have a fluoroquinolone resistance. I'm talking about the index case now. So for the index case, it is purely rifampicin resistant and no other resistance is seen. In such cases, rule out active TB in the contact and then you can start that particular contact on 6 months of levofloxacin. And this is the dosage. For each of the weight bands, the dosages are very clearly mentioned. There's another regimen which is 4 months of rifampicin for contacts of isoniazid resistant index TB patients. So you know that there are many patients, at least in Karnataka, we have 1,500 isoniazid resistant cases. Their rifampicin is alive, their rifampicin is sensitive, but they have isoniazid resistance. For all such cases, you will have to give 4 months of rifampicin to the contacts. Provided you rule out active TB, please do not forget that especially in contacts of drug-resistant TB, you will have to very actively rule out tuberculosis. And if there is tuberculosis, there is no question of, looking at the TPT. So whenever you have a H monopoly regimen in the family, and for all those contacts of this H monopoly regimen patient, you will be able to start on 4 months of rifampicin. Now, this is the biggest risk which the program is now moving towards, thinking that we have ruled out active TB to all our satisfaction. If you don't do that, and if you start somebody on 4 months of rifampicin, inadvertently, we will be landing up in drug resistance, especially MDR or RR. Adverse events with levofloxacin are very minimal. However, we've been seeing and using levofloxacin for almost years together, not just for TB, but also for non-TB conditions. There's one special, condition, a rare condition wherein there is development of diarrhea that does not stop, and there could be abdominal or stomach pain or cramping. So in all these, do not use anti-diarrhea or opioid medications, and you will have to better stop the levofloxacin because it is a condition where there is some mimicking of this Clostridium difficile sort of diarrhea. So there are other adverse events of rifampicin. Of course, rifampicin is a very, very safe drug. These are all very rare conditions, especially when rifampicin is to be used as a TPT. So I'm actually heading towards the monitoring and treatment outcomes, which are mostly programmatic. So I will not take you through the outcome per se or the monitoring aspects of the program. But let me tell you that this one particular slide is important, which means just look at the slide. The various regimens are actually enlisted here. The first one is 6 months of isoniazid daily. The second one is 3 months of isoniazid and rifapentin, which is a weekly regimen. The third one is 6 months of levofloxacin daily given to any contact of an index TB patient who is actually a purely rifampicin resistant TB patient without any fluoroquinolone resistance. The other one is a 4 months of rifampicin regimen given to the contacts of isoniazid resistant TB patients. In all the conditions, you will have to first rule out active TB, only then proceed towards starting any of these regimens. Now, the total duration is in months is what has been given in the column 2. 6 months of H, 3 months of HP, 6 months of levo, and 4 months of R. So the expected number of doses is given here. 180 doses in 6 months of H, 12 doses, which is weekly 1 dose here, 180 doses in 6 months of levofloxacin, and 120 doses in case of 4 months of rifampicin. Now, the game changer again here is that one person need not complete the entire course. Even if they have taken 80% of the recommended days, we consider the TPT as completed. This is important. The second one is, here we give them a buffer period of 33% additional time. So it need not be in 180 doses. It can the person can take up to 239 days. It need not happen exactly in these 12. It can happen in 120 days. Usually 3 months is 120 days. So instead of 90 days, it can go up to 120 days is what has been shown here. The third one is 180 doses of levofloxacin, but you can take a buffer period of 33% additional time. They can complete it within this 239 days. For 4 months of rifampicin, instead of 120 days, they can even spill over to 160 days. So here it is, instead of 90 days, it can spill over to 120 days. So all in all, we give them a buffer time of 33%, keeping in mind that there could be a lot of missed doses. The other thing we keep in mind is they need not complete all the doses. Even if they have completed 80% of the doses, we will declare them as treatment completed. So this is mostly for programmatic benefit, but for you it is important to monitor the prognosis. Also important to see that these patients do not develop TB at a later point in time. So again, these are programmatic definitions. So that's it from my side. Thank you very much. I'll be able to take any queries henceforth.
Thank you, ma'am, for that wonderful session by you. So I now request the audience that the feedback form will be shared here in the chat box as well as in the YouTube comment section. Kindly fill the feedback form and we will be mailing the participation certificate for you in a couple of days. The platform is now open for discussion.
Thank you, Dr. Shasia, for a wonderful presentation. And I was there throughout the presentation. Yes, you have simplified it, tried to simplify it as much as possible. And I hope that everybody would have been able to understand it in a short period of time. I have one question from you, that how exactly is being implemented in field, basically? Who are the workers involved? Who are the workers involved in implementing this?
Thank you, sir. A very, very important and pertinent question, especially now that the program has started adopting this as a policy. At least as far as Karnataka goes, we have now budgeted enough of amount for the IGRA testing and also for the drugs which are required. Currently, rifapentil is not available in the market. As of now, we are managing with isoniazid. Out of the 30 districts in Karnataka, at least 17 districts have rolled out TPT among the contacts of the TB patients, both drug-resistant and drug-sensitive TB patients. We are signing sort of MOUs with medical colleges and private labs who can actually harbor these IGRA machines. Also with the district public health laboratories where the ELISA test and the IGRA test are available in the private market and the public sector. So this is how MOUs are being signed, sir. But we are now finding a difference in the infection positivity rate. So sometimes it varies up to 80% in some districts, and sometimes the IGRA positivity is just 30% in some districts. So we will have to study the epidemiology furthermore in these aspects, sir.
Thank you, ma'am, for that particular response. Ma'am, there are some questions. I'll just put it across.
Yes, Dr. Akshay, please.
Madam, Dr. Anand has asked, Madam, can you enlighten us with the role of CTB in LTBI diagnosis and how it is planned to be implemented in the program?
Thank you, Dr. Anand. This is an update actually, and we had the good news in the latest World TB Day event which happened in Delhi on 24th March this year. and CTP will be launched very soon. Probably it's going to replace IGRA very soon, but the availability is again of concern, and studies are being done maybe in 5 selected states in the country as far as CTP rollout is concerned. So once the availability is confirmed, probably Karnataka will vouch for it. So definitely it is a big game changer if at all IGRA can be replaced with CTP in the coming days.
Ma'am, next question is any provision for neighbors of DRTB to get TPT? Dr. Maltesh says that he has seen many neighborhood kids playing along with DRTB patient during the field visits.
So yes, that's a good suggestion. It's not just neighbors. We consider not just the household contacts, but also the workplace contacts, especially in schools or maybe industries. We can take them. The other healthcare workers basically are the priority groups for offer of TPT. But I would suggest that all these groups may be taken up as a OR mode rather than on a direct program implementation mode. So if you really have a lot of neighborhood contacts of DRTB patients, please evaluate them for and rule out them for active TB and then evaluate them for TPT, and you can start them on the TPT. But let it go on a operational research mode rather than on a program implementation mode.
Hello.
Yes, sir. Dr. Girish,
Hello.
yes.
Can I speak? Regarding the IGRA, and will be for the infection, we will be giving the levofloxacin. Is like what are the chances of resistance and all? Is there any studies and how far it's effective? What's the we have evidence regarding that or something? I wanted to know.
Yeah, very good question, Dr. Girish. In fact, I just have to open up to all of you that please understand that we are not treating anybody who is, on an active mode. So there is no bacilli which is actively multiplying in the body. So we all understand that we are treating the TB infection. That is the reason I kept on telling you throughout the presentation that we will have to rule out active TB before we start somebody on TPT, and not just symptomatically, but we are also doing an X-ray. And if you find any abnormality in X-ray, we are thoroughly, proposing it to a NAT and then ruling out active TB, confirming ourselves doubly. Only then we will start the person on TPT. Now, whether it is levofloxacin or rifampicin or isoniazid or 3 months of isoniazid with rifapentin, the risk is zero. The risk of developing active TB or the risk of developing drug-resistant TB is zero. Why zero? Because the bacilli is not actively multiplying and thereby it will not develop any mutations. The whole idea of giving a chemoprophylaxis or a prophylactic therapy is to prolong the latency, is to prolong the sleepiness of that bacilli. So we are only prolonging that phase of latency in that particular person who is a contact. So absolutely there won't be fears that this person developed active TB or developed drug-resistant TB because of TPT. Provided you have ruled out active TB before starting on TPT. That is the only word of caution. As of now, we have no such, studies as of now in India to prove the effectiveness of levofloxacin or to prove the effectiveness of 4 months of rifampicin under programmatic conditions. Maybe down the line this year, we might get a lot of evidence. But one evidence is very clear that almost for 4 or 5 years now, we are implementing the PLHIV patients being given on, TPT regimen. We hardly have seen any active TB cases after the regimen is over. Does that clarify, Dr. Girish?
Yeah, ma'am. The thing is how far it's been rolled out in India, in any other states?
Almost all the states have now taken this up as a program policy, Dr. Girish, and by September, it seems all the states will be rolling out TPT among all the contacts and the other high-risk groups which I mentioned in the PPT.
The thing is, one more thing is, because we talk so much about, even WHO talk about the drug resistance. So with we may miss out the drug or what if you so widely if you use this. In general, it's maybe, as you mentioned, ma'am, it may not be affecting to the TB. Okay, I agree with whatever you mentioned. There's no active TB baseline, everything you have mentioned. But if like in general, it may not lead to the drug resistance itself, because as you mentioned, the levofloxacin is not just for use for the TB. It's again a good drug to be used in many respiratory infections. So does we may lose that drug that way?
No, the same logic applies, Dr. Girish. When you are using it for other conditions apart from TB, you must understand that there is again no actively multiplying TB bacilli in the body. Even if you use it for other conditions, it would be in the latent phase, so it will actually be benefited rather than being harmful, especially if it is some other condition apart from TB. But as you said, inadvertent use of levofloxacin without ruling out active TB is definitely dangerous. It might land us up with a lot of drug resistance in case in the private market or otherwise we have not ruled out active TB and started on these monotherapies. Monotherapies could just be a boomerang to the program, if at all we have not ruled out active TB.
Yeah, but is what I feel is the sort of urgency we are doing in the program without evidence.
No, Dr. Girish, I think there's been a lot of evidence in the program after clinical trials. This is the first time we are implementing it in program mode, but there have been a lot of clinical trials which have happened. And this is high time. When we are looking at TB elimination by 2025, we must have strategies for TB prevention. And I think this is a very good move from the government of India that we are thinking of preventing TB at least among the high-risk groups. We are not talking about the 35 to 40 crore population. We are only considering those high-risk groups who have high chances of developing tuberculosis. I think it is a very good move if implemented promptly.
Thank you, madam.
Madam, there is one more question in the chat box. What is the frequency of one second. Yeah, what is the frequency of giving TPT to an eligible contact? Within bracket, how many cycles? More so in first is PLHIV and second is those who have already completed TPT.
Okay. Again, a very, very important, very good question. Actually, they say that it is enough for a lifetime, one cycle. So one cycle of 6 months of isoniazid or 3 months of INH and rifampicin will serve the purpose for a lifetime. You need not repeat the cycle again. The other thing is, even if somebody is cured of tuberculosis today, that means he has completed the anti-TB treatment for 6 months today, tomorrow you can start this person on TPT. So this is what the guideline as of now says. There is no evidence of starting another cycle a little later or after some years, nothing of that sort. They say that one cycle, that is one course of this 6-month regimen or the 3-month regimen would be sufficient for the whole life.
Yeah, any other questions? I can see some people raising their hands. Okay, I think it's a similar question which has been asked. One more in the chat box. Is there any time period for the protectiveness of TPT? I think you have already clarified that. So any other questions? Any other questions? Yeah, request all the participants to fill up the feedback form, which will link to their certificate delivery, so which will happen in a couple of days' time. There was a problem with linking that particular certificate. However, it will be delivered to your email in a couple of days' time. So, last time, are there any questions to be asked? Okay, fine. Thanks a lot, ma'am. Thanks for your valuable time, and it was a very enriching session on TPT in programmatic context. So I call upon Dr. Pavitra to take over and deliver the vote of thanks.
Yeah. Excellent session. I think the interaction and the question answers that followed your session itself reflects the success of delivery of your content, and it was very well taken and everybody was very attentive, and that is how the clarifying questions came up. So as always, it was a very excellent and informative session. Thank you from my side.
Thank you everyone.
Over to Dr. Pavitra.
Thank you, ma'am. It's my pleasure to propose the vote of thanks on this occasion. I express my sincere and heartfelt gratitude to the Honorable Chancellor of Yenagoa deemed to be University, Yenagoa Abdullah Kundi, for the constant encouragement and support. I express my heartfelt gratitude to our Honorable Pro-Chancellor, Mr. Farad Yenagoa, for his constant encouragement and support. I express my heartfelt gratitude to our Honorable Vice Chancellor, Dr. M. Vijay Kumar, and our Registrar, Dr. K. S. Gangadhar Somayaji, for extending their constant support and motivation. I also express my gratitude to Dr. Harivansh Chopra, sir, former Professor and Head, Department of Community Medicine, NLRM Medical College, Meerut, for taking his time out and for gracing the occasion. Thank you so much, sir. I would also like to thank Dr. M.S. Musabba, Principal, Yenagoa Medical College, for his constant support. I extend my sincere gratitude to Dr. Abhayas Nirgude and Dr. Ashwini Dutt, sir, for Associate Deans, Yenagoa Medical College, for their constant support and encouragement provided. I thank sincerely Dr. Shasia Anjum, Medical Consultant, Karnataka State HQ, WHO NTP Technical Support Network, for gracing the occasion and for delivering an excellent guest lecture. Thank you so much, ma'am. I would like to express my gratitude to Dr. Poonam Arnaik, our Professor and Head, Department of Community Medicine, and also organizing chairperson for today's event, for her invaluable guidance and support. Thank you, ma'am. I would extend my sincere gratitude to Dr. Akshay KM, Additional Professor, Department of Community Medicine, also our NTEP Nodal Officer, Organizing Secretary for today's event, for his guidance and support. I thank Department of IT, Yenagoa deemed to be University, for their support in the successful conduction of this online program. I thank all faculty, PGs, staff from Department of Community Medicine for their invaluable support and effort for organizing this program. My sincere gratitude is also towards our photographer, Mr. Hem Chandra, for covering the program. Finally, I thank each and everyone gathered over here for making this event a successful one. Thank you all.
Thank you all. Thank you, sir. Thank you, Dr. Shazia.
Thank you, ma'am. Thank you, everyone.
Thank you, ma'am.